As you can see over here, that's a preparation. For an for an Emax bonded porcelain crown. So we used to enjoy all these preparations. I'm not saying that this type of dentistry is outdated or obsolete or something like that. See, we need every type of dentistry. So today we are going to deal with those type of restorations wherein we can manage the restoration without touching the tooth with a burr, or in certain cases with minimal, very minimal tooth preparation. See, in such a topic, when we are discussing such a topic, there are a lot of restorative things which we have to discuss. Like we can discuss about direct restorations, we can discuss about indirects, we can discuss about the semi-directs as well as the semi-indirects. So due to the time available, I would stick on to direct composite restorations for today. So the topic would be PREPLESS dentistry in direct composite restorations. So before starting with the topic, let me give a briefing of what all things we can do in such type of PREPLESS dentistry. In this picture, we can see this is a case of black triangles in the mandibular anteriors. Black triangles are nothing but exaggerated gingival embrasure spaces. And this is mostly a nightmare to the clinician to manage. And whenever we have to manage such cases, we always used to think of multiple treatment options. We would think of veneers. We would think of a lot of things wherein we have to squeeze the papilla to make it come up. So we would land up in tremendous tooth preparation in most of the cases. So let me show you a technique wherein we can manage this case without any preparation. So that's what you see over here. So that case is transformed into something like this, wherein, so we will be having a detailed discussion of how we went about in getting such a result. And you can see a totally inflammation-free gingiva over here. So these results are possible without preparation when we stick on to the proper techniques. See, why PREPLESS dentistry is important? In dentistry, there are many procedures wherein we require some aesthetic correction of the existing situation of the patient. In such cases, the otherwise healthy dentition, most of the time we would end up in grinding the natural enamel, which is not really a patient-centric treatment protocol. See, I'm not saying that in each and every case we can manage without any preparation. No, there are certain indications. The case selection should be very important when we plan PREPLESS dentistry. So let's see how we'll go about. So first of all, we have to evaluate the incisal profile. Incisal profile determines the relationship of the maxillary anteriors in relation to the vermilion border. Vermilion border is the border between the wet and the dry areas of the lip. If the maxillary incisors are into the wet areas, that means that the teeth are retroclined. So we can very well go ahead and add composites without tooth preparation. That is the main advantage in such cases wherein when the incisal edges of the maxillary anteriors are into the wet areas of the lower lip. If at all the situation is the inverse, that is, if at all the maxillary anteriors are into the dry areas, you have to consider it as an ortho case and nothing is possible. No PREPLESS dentistry is possible in such cases. So this is one important criteria for us in case selection. And let's see what all are the different situations which we manage PREPLESSly. So we can manage peg lateral incisors. You can see the peg-shaped lateral incisors. In this case, it is not a peg-shaped lateral incisor, which is a congenital defect. It is not like that here. It is an iatrogenically pegged lateral incisor. That is, someone has prepared it for a crown, and later the crown was lost. So now it is something like a peg lateral incisor. So that was converted into a normal lateral incisor without doing any further preparations over here. And then you can see the diastema closures, and you can see the beautiful emergence profile in such cases when managed PREPLESSly. Then we can manage the black triangles, as you have seen in the picture, the slide just before. We can manage black triangles. And in the bottom left corner, you would be seeing diastema with mild rotation of the mandibular anteriors. Again, we can see how beautifully we have managed without any preparation, and even the emergence profile, the squeezing of the gingival papilla, everything has come out nice in this case. Then you can see a diastema with a bit of incisal angle fracture, and that too. Those situations can also be managed without any tooth prep. The other one is an existing composite restoration, wherein you can see that the old composites have streamed. There is a bit of blocking in. The left lateral incisor is a bit blocked in. The left central incisor is slightly distally tilted, and that situation was nicely corrected without doing any further damage to the teeth. So these are the normal situations which we manage PREPLESSly. So I'm just giving you an overview of the different situations which we would be managing in PREPLESS dentistry. So that's my habitat, the place where we enjoy dentistry in Kochi. That's my clinic, the Outlook Center for Advanced Dentistry at Kochi. Now, let's begin our journey with direct composite restorations that's engineered perfectly, yet simple, monolithic, compact, and pragmatic. So let's start with the pegged. In the sense why I say pegged is, this is not a peg lateral incisor actually, which was iatrogenically made like a peg lateral incisor. So there was a crown given on this lateral incisor. The crown, excuse me, please, dear participants, for the effective communication of things, I would expect equal responsibility from you all. See, it's really a disturbance when you don't mute your mics. Please show your responsibility. Fine. So you can see the case here. That's a crown preparation was done over here. The crown was lost. Obviously, the crown would be lost because there is no parallelism of the sides followed in this case. So that is how most of the time dentistry happens, sadly. See, in the dentistry which we were practicing some time back, we were taught that enamel is a very good substrate for bonding, and dentin is a vulnerable bond. That is, you get very good bonding to enamel and a vulnerable bond with the dentin. So things have changed. Like every branch of science, dentistry too is a branch of science which we all have to agree to that. And any branch of science, we all know that it's never static. Things are dynamic. There are newer things developing. There are researches happening in the field. And now we could say that the bond to dentin is in fact better than the bond to the enamel. So we have to do a procedure called the immediate dentin sealing. So you can see the root stump was immediate dentin sealed, and I've placed a horizontal layer of composite just to support my matrices. No preparation, nothing has been done on the tooth, just coated with a bit of flowable resin as immediate dentin seal, as the resin coat over the immediate dentin sealing, a bit of composite. So as to support the matrices. Dr. Fajna, if you can mute all the participants, it would be good. It's
Okay,
like
doctor.
we're tired of telling everyone. And now you can see that we have placed the 360-degree veneer matrices. These are very special matrices called the 360-degree veneer matrices. It is available as a two-part form. It has a mesial part form and a distal part form. So we place both of them incisor-cervically. It goes into the sulcus, stops at the bottom of the sulcus, and it has a cervically self-sealing design. So once that is done, we would injection mold warm composite into the mold space, and thus a beautiful composite restoration is completed without any further damage to the tooth. So let me begin with this case. I hope you have understood the different steps which has gone in this restoration. Now let's talk a bit about the matrices. Fine. So basically in injection molding, or whenever we are managing such cases with a single shade and warm composites without any tooth preparation. So the buzzword here is without any tooth preparation, we would be resorting to certain special matrices and certain special composite placement technique. So I would not be able to stretch this discussion over the entire range of the matrices available, but I limit it with the black triangle matrix. So here, it's like, though it's called a black triangle matrix, you can use it in black triangles, in managing black triangles, as well as in managing the diastemas. The first thing that you would do would be, you would pass on the probe, the color-coded probe, which comes along with the system into the diastema of the black triangle, and see till which color code the probe goes in. And you would be selecting the matrix band with the similar color on the matrix. So that is how we go about with the matrix selection. So the matrices would be placed as you would see here in the picture. So let's have a detailed video.
Don actually traveled from another state after doing an internet search.
So you can see these are the preoperative picture you would have seen. Then we would be applying disclosing agent, followed by we would be sandblasting and removing all the plaque biofilms. The tooth is very clean now. It has to be done onto clean enamel. And after that, we would be placing the matrices. Etch it. Apply the bonding agent. Don't cure it. Inject the flowable. And over the flowable, we would be injecting the packable composite. Pack it all nicely.
Resin in the gingival surface. A browning point in an electric hand piece at medium. With those hand problems, you can really begin to appreciate this important advancement in both aesthetic.
So you have seen the video wherein it is like we would pack the matrices and then we would be injecting the flowables and packables. Now let's come to something like this, a very, very, very tricky case. So this person had broken the coronal aspect of the tooth, a very aged person. I took an IUPA and it was a totally sclerosed canal, and someone in her 90s, wherein it is like I was not planning to go ahead with the root canal treatment since the tooth was asymptomatic. There was no periapical issues in this case. So after the immediate dentin sealing, just 2 extensions of composite so as to support my matrix. Place the matrix. You can see the palatal aspect as well. Injection mold. Finish and polish. So you have seen over here that we are using spatial matrices, and we are using injection molding as our composite placement technique. That's the before and after. Now it's like few of you may ask whether this is going to last. This is going to last if at all we have fine-tuned the occlusion. If the occlusion is not taken care of, this will never last. So this IOPA would tell you a lot of things. You can see on the canine as well as the central incisor, you can see that since the patient is missing her posterior teeth, there is overclosure, and you can see the wear facets. If you follow my cursor, you can see on the palatal aspect. So the patient was not inclined towards restoring her posterior dentition. So what I have to do over here is to work with the palatal inclined planes. So you can see that we have worked with all the palatal inclined planes so as to equilibrate the guidances, and such corrections needs to be incorporated in the restoration so as to improve the longevity. And you can see that when we injection mold composite, you can see it's a monolithic structure. You will not see any voids over here, and you will see a lifelike appearance. You can see the beautiful line angles, you can see the beautiful luster, everything. So this is, I would say, 100% patient-centric dentistry. So let's see another case. So I'm pushing on to the limits of the minimal preparation techniques. So here already a crown has been given, and due to the leaky crown, so everything landed in a big chaos. You can see a huge lesion. It was leaking. The entire respiration was leaking. The root canal has to be repeated now. The post has to be repeated now. And the post was retrieved. Retreatment was completed. And once I removed the crown, I understood I am in a total mess. The structure inside was totally sloughened, and there is no further room for me for any other preparation now. Fine. So I planned on a totally additive procedure. So the retreatment was completed, and to reinforce the weak radicular dentin, you can see the polyethylene fibers, the high molecular weight polyethylene fibers, or the ribbon fibers used as a wallpapering inside the radicular dentin horizontally. Yep, you can see that the colored area there. And another piece of ribbon fiber was kept vertically so as to improve on the reinforcement inside the root. So that's a structure which was a provisional buildup which was done with a dual cure composite. Later, it's like on that structure, a 360-degree veneer matrix was placed and injection molded, and that's the follow-up. And it's a 1 week follow-up. You can see the tissues responding, healing nicely. And you can see 3 months post-operative, wherein you can see that the lesion is healing now. So 3 months post-operative, you can see evident lesion healing. And that's a 5-year follow-up of the same case. And you can see beautiful soft tissue, nice biotype around inflammation free around the prosthesis. Fine, no crowns, nothing was given. It was just an add-on composite over the old crown preparation without any further reduction. Again, cases like this, wherein it is like the pericervical dentin is already gone with the decay. The tooth is already root canal treated, and we don't have any further scope for a crown preparation here. You can see the radicular dentin is too thin. We will not be able to do a crown preparation. Such cases, again, we place a matrix, injection mold, finish and polish. So this is the scope of dentistry. This is the scope of minimally invasive dentistry. That is, we can restore all these situations without focusing on the tooth preparation. Now, let's come to another interesting case. flared central incisors with huge diastema. So when we are managing such huge spaces, the first thing we need to do is we need to do a mock-up to make sure that the increased width is going to look acceptable to the patient. So that's very, very important. See, managing a 1 mm or 2 mm or maybe 3 mm diastema is also, it's all fine. But here it's like you have a huge diastema. So you have to do a mock-up so as to make sure that things are going to work in your favor and as well as the patient is going to like it. Fine. So after the patient's approval, we have to plan the final restoration. So here I have a huge diastema to be closed. Then we have to do some changes so as to give an appearance that the tooth, the angulation of the tooth is much more straighter. The flaring has to be somehow masked. And then the emergence profile needs to be corrected. So I have to squeeze the papilla and make it come down. So these are the challenges over here. So I went ahead with a mock-up. So without etching and bonding, with the black triangle matrices in place, I just injection molded a bit of composite, cured it. And now I'm sure that I can squeeze the matrix over here. I'm sorry, I can squeeze the papilla over here. So these are the two shelves which we have created, the pieces of mock-ups on both the central incisor. Now they have a purpose. So I'm not going to touch the tooth with a burr. As we have seen in the first video with your sandblaster, you would be removing all the plaque biofilms from the surface of the tooth. Then instead of just one matrix to close the diastema, I've placed another matrix on the distal side also, so that when you bulk up from the distal, it gives an appearance that the tooth is much more straight. Fine. So all this without any tooth preparation. And for me, not to lose the midline, to keep the width of the central incisors similar, I'm using the shelf which I've made as my mock-up initially, that I've attached onto to the adjacent tooth, so that it is going to guide me during my work. Now that's the final result. You can see the diastema is nicely closed without any preparation. Now we have given an appearance that the tooth is straighter. We have squeezed the papilla nicely. And this is how we manage a case without any tooth preparation. So that's the same case with the studio lights, and you can see. And you have an IOPA. I have an IOPA also, which is given below, wherein you can see that there is no voids. The adaptation of composite is superb. So all these things are possible only when you injection mold. Yet another case wherein you can see that the level of both the central incisors are different. One tooth is a bit proclined than the other. So you can say mild malalignment with a diastema. Obviously, this has to be an orthorelapse. So it's a split dam on, and I was just checking in the matrices. I'm using matrices on both the mesial and the distal sides, so that this gives me much more freedom of managing both the contours, both the proximal contours, and then injection molded. As the final result, you can see that the diastema is managed, both the teeth, they are in the same plane now, and all this without any tooth preparation. And you can see the comparison between the pre and the post. And you can see the proclination of one tooth, proclination of the 2-1 is corrected now. Though we didn't, it's basically a minimal addition on the 2-1 and a bit more of addition on the 1-1, which has worked out over here. That's the pre and the post. Now let's see another case. Here it's like it's very minimally invasive. It's like I had to adjust the cant. The maxilla has got a cant over here. So the first thing was to do a bit of gingivectomy so as to get the zeniths in the same line and give an appearance that the cant of maxilla is not present, and then a bit of enameloplasty along the incisal edges so as to give a straighter appearance to the maxilla, so as to mask the cant of the maxilla. This is the only preparation. There is no buccal reduction being done. The matrices are placed, composites are added, finished and polished. Let's see final result. So I guess now you have seen enough and more cases wherein we have discussed many situations wherein we can work without tooth preparation. And this was a case which we were discussing in the beginning. You can see multiple black triangles. You can see a diastema between the lateral incisor and the canine. And you can see the matrices placed, the worm composites injected, as you have seen in the video, plus the diastema 2 managed. The excess of all the excess composites trimmed out, finished and polished. And you can see the emergence profile after the diastema closure. The papilla is nicely squeezed so that it comes up to close the black triangle. And that is the 1 month follow-up. There is absolutely no inflammation of the gingiva. There is no black triangles present. The diastema is very well managed, and all these achieved without any tooth preparation. And the saddest part is something which we see routinely in our countries after the ortho, when the orthodontist or the general dentist debonds, they take their burr and remove all the cement excess with the burr and create burr marks on the tooth. So this is something which is very bad. We should not do all these things being dentists. So another case, similar case wherein there is diastema, the teeth is the centrals are a bit rotated inside. So it's very simple, no need of any grinding. Just place the matrices and injection mold and give an appearance that everything is straight and fine. It's all additive dentistry, and you can see in the follow-up, no gingival inflammation, excellent emergence profile. There is no black triangles present, and above all, it gels nicely with the shade of the tooth. That's the pre and the post. So a case wherein I had to remove all the old composites. You can see a lot of discolored old composites. You can see the lateral incisor. The 2-2 is a bit blocked in, a slightly rotated central incisor. You can see the old respirations there. The uneven width of the centrals. Blocked in laterals. So the old composites was removed just by air abrasion with AquaCare, so that no enamel, no dentin remains. I mean, it's like we don't cut the enamel or the dentin. Just with proper adequate pressure on the AquaCare, we would be able to remove all the old composites and then injection molded. So with very minimal preparation, we are able to get fabulous results with composite restorations. So diastema, something which can be, I would say that the diastema management and black triangle management are the forte in PREPLESS dentistry. They can be beautifully managed without touching the burr. Again, rubber dam isolation, disclosing agent, you have to remove all the plaque biofilms present, and for me to not lose the midline, a bit of composite placed towards incisal edges, so that when I place the matrices, both the central incisor would be having equal width. Otherwise, if the matrix shift to either of the sides, one central may look a bit wider and the other narrower. To avoid that, to get a proper orientation, I would place a bit of composite towards incisal edges in the beginning. Place the matrices, injection mold, finish and polish. So that's the beauty of the system. No need of any tooth preparation in diastema closures. Another case, similar thing. You can see the beautiful emergence profile, and the composite nicely blends with the rest of the tooth. And the biggest advantage, no need of tooth preparation, no bevels, nothing. A class 4 fracture with a small diastema. So for me to get an orientation of the midline, a bit of composites placed over here, which would guide the matrix. Matrice is placed, injection molded, finished and polished. Again, zero prep. So this was a premarital dentistry, wherein it was like just before the marriage, the patient was bothered about the diastema and severe tilt of her teeth. So let's see how we can manage. So no preparation, nothing, just the matrices were placed and injection molded, and you can see the fabulous. I'm not saying that this is perfect, fine, but at least we have not harmed her natural teeth. It's all additive dentistry. You can see the difference between the pre and the post. And not only in the anteriors, we would use these techniques in posteriors also. So a heavily, badly mutilated tooth. So in such cases, I'm not saying that we can do without any preparation. We need to trim out all the unsupported enamel here. All the unsupported enamel was trimmed away. Fine, I had to remove all the soft caries. Then immediate dentin sealing was done. The rebond was placed to absorb the stresses. Then a direct composite, an indirect composite overlay was made. That's the overlay on the silicone die. And that was bonded onto the tooth. And you can see the post-operative result, the fabulous merging, adaptation of the prosthesis onto the tooth. Fine. There was no scope of any preparation in such cases. And most of the time we would be thinking about crown lengthening, root canal treatment, post and core, a lot of things. So nothing was done. Things were fine. Things are going on fine. So that is the advantage of PREPLESS dentistry. So the key thought process behind all these things is do no harm. Now the case, a deep caries case, wherein the proximals are intact. So I would just block out the decay with a bit of resin, make an index, a clear polyvinyl siloxane index before the treatment. The tooth had to be root canal treated. A root canal treatment was done. An impression was made. And then it is like an indirect composite onlay was fabricated, which was bonded onto the tooth. And you can see there is no need of a crown. There is no post and core, nothing. It's all very simple dentistry, very, very, very minimally invasive. And this is the scope of PREPLESS dentistry. And yep, there are many cases like this. Here it was like this patient had lost a tooth, and his former dentist he took the avulse tooth, chopped off the root, and this was bonded with a palatal strip of wire onto the rest of the teeth. But the issue was the aesthetic outcome was bad. And that was the main concern of the patient. And he came to me with his old photographs. And you can see these are all composite restorations done. And they're also looking a bit shabby. So we had to change. So the pontic, which was connected with the wires, were removed off. All the old composites was removed. And one central incisor was already root canal treated. I didn't want to do any further preparation over here. Just injection molded. And it is like when I injection mold the central and lateral, it would take up the shape of the matrix. But the natural tooth over there would have a different shape. Fine. So first what we did is we took the coronal portion of the tooth, stabilized it inside some silicone, placed the matrices and injection molded that, so that for all the teeth, the contours and the shape, they looks similar. And then it was like a bridge was given with wherein posteriorly it was bonded with high molecular weight polyethylene fibers. And then finally, the occlusal equilibration was done. The high points were removed, finished and polished, and that's the appearance. So here it's not zero prep, very minimal preparation being done. So this is just an overview about different things which we do in PREPLESS dentistry. This is not everything about it. There is a lot of things wherein it's like there's a lot of cases which needs to be seen, which needs to be understood, which need to be discussed, but within this short time frame, that is not possible. That is why I restricted this only with direct composite restorations. It's like there is always a scope of PREPLESS dentistry. We have the PREPLESS indirect veneers also. So maybe in some other time, we would be discussing about the indirect restorations without tooth preparation, that is PREPLESS indirect dentistry. So I hope you have enjoyed the cases, and I hope I was able to convey that the advantages of dentistry without doing too much of tooth preparation. So, and thank you all for the patient hearing. And to get more information regarding these cases, you can log into my Instagram account. You can scan the QR code and log into my Instagram account, wherein you would be seeing a lot of similar such cases. And if you find interest in going ahead with this type of dentistry or biomimetics or restorative dentistry, adhesion-oriented restorative dentistry, you can always contact us. You can join our programs. You can join our webinars or the physical workshops. So thank you all, and we'll have a short time for clarifying your doubts. So if at all you have any doubts, please unmute yourself and you can go ahead and ask. So thank you all. It was great spending some time with you all. And yep. Good night.
But one question is there. In
Yep.
IDS, we need to acid etch or no need to acid etch? Just apply bonding agent, light cure, and then apply flowable composite.
Depends upon your bonding agent. You have to use your 6th generation bonding agent there. Okay, using your 6th generation bonding agent, you don't require to acid etch.
What do you mean by fusing the papilla or filling the black triangle and replacing composite?
I'm sorry, your voice is breaking.
Sir, what do you mean by fusing the papilla for filling the when you place the composite?
That's called the principle which has been utilized over there is called Tarnow's principle. What Tarnow found out is when there is presence of bone within 5 millimeter from the tip of the interdental papilla, if you can space the papilla will grow down to fill the space.
Okay. So we just have to place the composite filling from the in 5 millimeter.
Pardon, sir, your voice is breaking.
Sir, so the composite filling, the apical end should be 5 millimeter from the bone. So we have to place it like that.
The tip of the papilla, from the tip of the papilla,
Okay.
there should be bone within 5 millimeter from the tip of the papilla. In such cases, the papilla can grow down.
Okay.
If you squeeze the papilla or if you compress the papilla. You can compress the papilla with a direct restorative material, or you can compress the papilla with your veneers also. Both are fine. Direct veneers also.
Sir, in your technique, BioClear technique, 360-degree
I
veneer
mean,
technique.
one small correction. It is not my technique. I'm not. I mean, it's all well established techniques and developed by the technique is developed by Dr. David Clark.
Okay,
Yep.
okay, sir.
Yep.
Sir, in this technique, after acid etch, no need to light cure the bond.
If you're all over enamel, you don't have to cure the bonding agent separately.
So you told about heating the composites. Sir, that injection molding composite also should be heated. And what is the purpose of doing it, sir?
See, when you heat the composite, it is like it becomes more flowable, right? It becomes honey-like in its viscosity. So it's much more easier to inject into the mold space.
So how to heat the composite, sir? Does any
You
instrument
have
specific
composite
for that?
bombers. You have composite
Oh,
bombers.
okay, sir. Thank you.
Okay.
Sir, now do we need wedges during this BioClear matrix, sir?
Of course, it depends on what type of case we are doing. If at all we have to compensate for the space of the matrix, we have to.
Because I didn't see any of the wedges in your
Yeah,
cases. There's
for a black triangle, I was specifying this. This has a cervically self-sealing.
okay.
Fine.
Okay,
So
sir.
by the matrix, they seal cervically well, but it is like imagine you're doing a diastema. In that case, you have to wedge and separate.
Okay, sir. Okay.
So I hope you all have done with your doubts. So once again, thank you all and good night.
Thank you, sir.
Thank you.